the Gerontological Society of America, Advancing Innovation in Aging. GSA on Aging. I'm Howard Degenholtz, social media editor of the Gerontologist, a publication of the Gerontological Society of America. This episode of the podcast is about the workforce in long-term care. The Gerontologist last year put out a special issue around workforce issues in long-term care. I interviewed Laura Wagner, one of the authors of an article in this issue, who is an expert in staffing and long-term care issues. And we discussed her paper, where she's the lead author, Medical Staffing Organization and Quality of Care Outcomes in Post-Acute Care Settings. We also discussed another article in the issue by Kezia Scales. Is it time to resolve the direct care workforce crisis in long-term care? Laura and I had a very, very deep and interesting conversation about this important topic. This is one of the longer episodes that we've put together. I really hope I can count on your attention because I think it is really worth it, because this is an important issue that has not gone away. Thank you for joining me today to talk about your work and the topic of workforce in general.
Of course. Happy to be here.
Thank you. So, Laura, I asked you to join the podcast because I wanted to talk about your paper in the special issue of the Gerontologist on workforce in long-term care. So in this study, there seems to be a dichotomy between outcomes for long-stay residents and outcomes for short-stay residents. What do you think is going on there?
Well, what I see, and maybe you're referencing that the providers seem to have more of an impact on the short stay measures. Is that what you're referencing? And
Yes.
that makes sense because they're more involved in the care, the day-to-day care of a short stay resident, especially if they're, Medicare Part A patients. And so they naturally would hopefully have more of an impact on those quality measures. They're less so involved in the care, the day-to-day care. It's actually, month-to-month care at that point in a long stay resident.
Well, so in some of the ones where there was statistical significance, they seem to go in the opposite direction. That is, ratings of better informal dynamics within with the staff at the facility seems to be associated with more falls and
that was with the long stay.
Right, with a long stay. And then also having a formal process for granting privileges seems to be associated with pressure ulcers. So you have, on the long stay, you have some of the indicators that would seem to be, from your theory, associated with better quality, actually associated with poor quality. And then on the short stay residents, it's going the opposite direction. So I'm very curious, what do we think is going on here?
Yeah, we actually debated that quite a bit. Was this a type 1 error because there were so many quality measures where there's sample issues? So we were kind of going in that direction at the end of the day and the other issue was just the sensitivity of the tool. We need to do further testing of the medical staffing organization.
Sure. As I was reading it, I was having the discussion, my internal monologue was exactly what you just said, which is this is a type 1 error. And as a researcher, I am always, when the finding goes in the direction I want, I think it's a true finding. When it goes in the finding I don't want, then it's a type 1 error, right? So... So, we've both done enough studies to know that we should be symmetrical on those biases. So if we want to interpret the finding that goes in our hypothesized direction, we have to be ready with a reasonable explanation on the ones that go in the opposite direction. Mm-hmm. Yeah. So one of the things that occurs to me about falls, I'm not sure about pressure ulcers, but one of the things about falls is that it's not necessarily an evidence of poor quality per se. It might actually be evidence of lower use of physical restraints, lower use of chemical restraints, and a little bit more autonomy on the part of residents, which is if we're giving residents more freedom to move about their room, to get in and out of bed, then that enhances their dignity and their daily experience, but it also exposes them to some risk.
Sure, definitely. That particular concept that we were measuring was more about the relationship between the physician and the staff. And it would be interesting to see in those facilities maybe that had higher falls, what was the relationship with the staff? Were they more likely to prescribe medications that could increase falls? Was there a falls committee, and was the physician part of that or not? So it's interesting to see how engaged is the physician in these facilities with these quality measures, especially some of these more long stay ones.
Yeah, like you would think that some of these measures, such as these informal dynamics, might be associated with some collaborative efforts around quality, which might essentially lead to efforts that have counterintuitive findings.
Yeah.
Right? So like depression is one, sort of the classic example where if you start paying attention to it and educate staff about depression, and you start to learn about the symptoms and the treatment opportunities, then they start to see it more and code it more, and it shows the prevalence of depression
will increase
on the in terms of the MDS assessment. So you start essentially becoming alert to these things, and then in principle improving the experience around these things.
And that's not necessarily a bad thing if you have a high prevalence of depression, if you think about it from that perspective.
Right. If our prior is that it's underdiagnosed and undertreated, then the first step towards appropriate level of treatment is getting it diagnosed when it exists. So the same could be said for some of the other outcomes that you're observing, and what you're picking up is something about the organizational process that might actually be a good organizational process.
Yeah. The discussion point that I would think about with this conversation, though, is it's not a reimbursable activity for a provider to be sitting down and having discussions about organizational level issues. So I think that's also, a challenge that we face is providers are very much focused on revenue generation and billing. And is that a billable expense if I need to come in and talk to the facility about how to work with improving outcomes with my residents on some of these quality measures?
That's a really good observation. And so just in this conversation, I've been on the train of thought that the way you get to having a good relationship between the physicians and the other staff is through conversations and meetings and focused attention to things like organizational approaches to quality, which sort of runs counter to what you just said. But there's another dynamic. I'm wondering if this rings true in your research, which is the physicians often have a lot of moral leadership in nursing homes. And staff do not want to do anything that the physician does not approve of with residents. And when the physicians ask for something or put something into the orders, that is considered to be sacrosanct in terms of what needs to happen for residents. So I'm curious if you've observed that and how that dynamic might be playing out in some of these data.
Yeah, other than the informal dynamics measure that we discussed about this relationship, I'm not really sure I can speak more about that. Other than anecdotally, I think what your observation is very true as far as the relationship between staff and physicians is certainly just a very top-down approach with less of a discussion, a back and forth discussion. And you're also dealing with a workforce that might be less trained in management of, medical management. So if you don't have let's say a nurse practitioner on staff that can maybe help with some of those discussions, that might impede that disconnect or increase that disconnect.
So one of the things that occurs to me is, again, thinking back to the findings around physicians that are employed, I've long thought that, okay, this is a important tool. This is an important solution to some of the quality problems. And notwithstanding whether the findings are ambiguous here, there's some clear signal that there are benefits. Why do we think there aren't more physicians in that relationship with, in an employment relationship? Does it have to do with the size of the facilities and the ability to hire full-time physicians? And part two of my question is about advanced practitioners and nurse practitioners. So I know that was not part of this study, but I'm wondering if what your perception is with regard to their role vis-a-vis quality of care.
Yeah, definitely. Yeah, I think to answer the first part of your question, I'm not sure how we can increase the engagement with physicians as employers of facilities. That would, I think, be a very expensive undertaking especially if it was a small facility. Certainly if there were larger chains, that might be more amenable to hiring physicians. There also is contractual issues around the reimbursement with Medicare. So you can't be employed by the facility directly with the Medicare reimbursement. There's some issues around that. So they'd have to be like a separate entity if they were going to be billing and stuff. So I think that there are some issues around that as well that would have to be considered. Many of the physicians that were in this study, or that that I've read about in other studies, are part of a chain of maybe SNFist, which was referenced in the Katz paper that I'm also an author on. That's another model of care where physicians are primarily only providing SNF level care. So they're not working in an outpatient setting and seeing patients in hospitals. They're only seeing long-term care patients, and they might go to multiple long-term care homes. So that seems to be more of a model that's amenable to the medical provider workforce. As far as you mentioned, nurse practitioners, physicians assistants, that we also discussed that in the Katz article that's in the same issue. There's substantial research on the use of nurse practitioners in long-term care, especially around outcomes, specifically around end-of-life discussions, emergency room transfers, infection management and prevention. So there's a lot of research that's been done in that area. One thing that we haven't discussed when we're talking about these quality measures, and this might be something to think about for future research, is when we look at the quality measures and the list of quality measures, both the long stay and the short stay measures, we might want to think about, if we're going to be if we had our ability to develop a new quality measure, if I had that within my, ability to do so, what quality measure would we develop, and what would be part of that quality measure that's specific to, or that's sensitive to medical care? So what would that entail? What would that look like? Because we don't really have one right now, a quality measure. We have some of these quality measures that could be sensitive or partially sensitive to the medical care that's being provided in these facilities.
Well, we have, the potentially avoidable hospitalizations. Is that what you're thinking? Along those lines, or something micro?
Something more micro that's more focused on the actual provider engagement with that patient. So does that include polypharmacy, for example? Are they prescribing the right medications? Is that client on a medication that's on the Beers list?
So, there are some data elements in the MDS, and there's a little bit of work on this sort of a proposed measure around medication review. Have you looked at that?
I think that only answers one piece of sort of the medical provider engagement that
you mentioned polypharmacy, so that was kind of my
that's one area. So does the client have an advance directive? That's another area that we want providers to be having those discussions with all of our residents in long-term care. So there's multiple areas where the provider is specifically in the position to engage with that resident on the quality of care, and what are the specific issues, and how can we kind of bring them together and come up with a quality measure that is provider centric.
What do you think what's the goal there? I mean, to measure, we want good quality of care, but physicians, as we know, are physician care, especially for the long stay resident, it's only a small fraction of the attention that they get. Where is that leading?
Well, where that's leading is that the physician or the nurse practitioner, physician's assistant, are a vital part of that person's care. And so they need to be included as part of the quality of care that's provided in long-term care. And that we need to find a way to better measure that, whether they're with, they visit them monthly or, less frequently or more frequently. All of these other quality measures, we're very focused on the nursing aspect, the staff nurse that's providing that day-to-day care, or the certified nursing assistants and all the staff, the nutrition. The other quality measures are focused on those staff members, but less so on the actual medical provider level.
So I'm glad that you mentioned that. One of the things that I observed in your analysis and the findings is that the nurse staffing measure also seems to have this bifurcated set of results with regard to the long stay and the short stay. And I'm wondering what you make of that. My read of the staffing literature suggests, I think that those things are usually more going in the same direction.
Yeah, again, that's where we were, discussing what were the limitations of the study with regards to the sample. We were dealing with probably an unusual sample. These were providers that were in facilities that had, potentially certified, medical director facilities. So we might have been dealing with a facility that's more engaged. So I guess at the end of the day, we were thinking that our sample might have been not a generalizable sample.
Mm-hmm. Let's shift gears and talk about the Scales article by Kezia Scales from PHI. So PHI, the Paraprofessional Healthcare Institute, is really an interesting organization. I think they do advocacy, and they produce training programs. They also do some in-house research, although usually more in the gray literature than the peer review literature. And they sort of play an important role, and I think they're unique in terms of their focus on the direct care workforce. Mm-hmm. So I think it's a really, certainly the title grabs your attention. Is it time to resolve the direct care workforce crisis in long-term care? I think they really put their finger on it. What was your reaction to this?
Well, obviously, I'm in this workspace every day, so it wasn't surprising, the Scales, what Kezia had to say about it. This is certainly, and it's great that you're focusing on this article, because this is really the wave of the future for long-term care and the workforce that needs the most attention and that we need to focus on. I think the title would not have been the title that it is had we not had a pandemic to kind of, throw us into that direction. So we're using this as an opportunity, the pandemic, if you will, as an opportunity to bring light to this workforce and the work that needs to be done to enhance the workforce, the direct care workforce.
I completely agree. So Kezia brings up a couple sort of technical things around the workforce. And I want to dig into that a little bit and get your sense on some of these ideas. The one that I think really is where they really lean on is this notion of upskilling and empowering direct care workers. I thought that was really interesting and potentially valuable concept. I'm curious your take on it. First off, in terms of how strong is the evidence base around upskilling and how practical is it?
Oh, so such a great question. As far as upskilling goes, I don't think there's a ton of research in this area. There's a few research articles that were referenced in the article around improving job satisfaction and job quality. But as far as workforce development programs, there's has not been a lot of research done on upskilling the workforce. We have small pockets of organizations that do this type, as PHI is very involved in this space. Right. Yes, as you've mentioned, they do a lot of upskilling, so I'm sure that's why it was included in the article. The funding that is not there. So how are we going to fund the upskilling of this workforce? I think is a question on a large scale.
So do we need a new Better Jobs, Better Care program? Do you remember that from Robert Wood Johnson?
Yeah, actually, Bob Casey in the Senate right now, there's some legislation. I don't know if you're familiar with the current legislation in the Senate, the Better Jobs, Better Care Act. It's Senate 2210. I think that's the bill number. And then Debbie Dingell of Michigan is sponsoring in the House the Home and Community-Based Services Act, Access Act. And so those two bills right now are in Congress, really focused on the direct care workforce. More so, though, is home and community-based services, less so focus on the long-term care workforce. So I think that is one area that, the nursing homes and SNFs setting was less of a focus in those two bills, and they're currently under review and for comment.
So I want to stay with the nursing home workforce for one moment before turning to the HCBS side.
Sure.
One challenge that to upskilling and empowering that I see in the nursing home is the challenge of rewarding people for generating new skills without necessarily promoting them out of the work that they like and the work that they find rewarding. I'm wondering if you have any, your perception on that and whether and how some of these programs kind of dance that line.
Do you mean, if I could clarify, if I upskill a worker, are they more likely, is there a turnover more likely where they're more likely to go and get a better job somewhere else if I've trained them? Is that what you're talking about?
Well, there's certainly a disincentive to training people because they might go and get a better job someplace else. But there's also this notion that what we pay for is not necessarily doing your job better, but being in a supervisory or management role where you're now sort of a team leader or shift leader and you're doing less direct care and more managing of other direct care workers. And then the work then is actually less rewarding for some people because what they value is the interpersonal connection with the residents as opposed to being the boss.
Yeah. There's some research on that. Kathy Magilton at the University of Toronto and Barbara Bowers is doing some research on supervision and the role of the supervisor. I'm not sure they've been focused more on the nursing supervisor and less on like CNAs, for example. If you're wanting to look at the really direct care workforce, I'd be interested in seeing more research at the CNA level or the LVN level. Yeah,
and where this sort of came up was giving CNAs the opportunity to essentially be on a training ladder towards earning an LPN, which then kind of puts them into a different job if they actually succeed in the training. So the challenge is improving their skills, improving their ability to do their job, making the job intrinsically more rewarding, but also helping people do the work that they want to do, right? And stay in the parts of the work, retain the parts of the work that are rewarding for them.
Is it necessarily a bad thing, though, for them to want to further their education if we can give them opportunities to?
Sure, but not everybody wants that.
Sure. Yeah.
And that's the challenge, right? They want to do a good job of what they're doing, but they don't necessarily want to be going back to school.
Yeah.
It's not for everybody. It's not for everybody. That's
for sure.
So one of the other tools that is mentioned in this article is value-based purchasing. And that's potentially a very valuable tool, especially with regard to Medicaid managed care plans and the opportunity to essentially incentivize providers to improve quality with gain sharing and other ways to essentially share in the savings. So I'm curious what you think about that and what's the potential there. I think we see some evidence, but I don't know how strong it is with regard to value-based purchasing in long-term care. There's been efforts in different states to do this in Medicaid programs.
Yeah, still very fairly new concept especially in long-term care. I guess my question around that is, how would you increase the workforce of let's say the CNA workforce using value-based care? That's the question that I would have is.
Well, okay, so that's I was still on the quality dimension and we hadn't gotten to the size of the labor force. I mean, I guess if you're able to use savings to increase wages, then that potentially brings more people into the marketplace.
Who's involved in that, though? I guess is who's driving the ship in that discussion? Is it the administrator? Is it the director of nursing, if we're thinking on the micro level, or is it the direct care staff? And what do the direct care staff know about value-based care is my question.
Mm-hmm. I don't think we know yet. And I don't think we know how well it gets down to the frontline staff. Like we did some work on some of these concepts. This was a really frustrating project that we did a number of years ago here in Pittsburgh, where we were going to do some gain sharing around reducing pressure ulcers. And the idea was, without putting specific dollars around it, if the facility reached a certain goal in terms of pressure ulcers, then there's an implicit savings there in terms of the cost of care. So there should be some reward to workers for having done all of the micro level steps that are required to prevent pressure ulcers, turn in position. So the problem was that once they reached the goal, the administration decided what the reward should be, instead of letting the workers choose the reward. So the gain sharing was sort of undermined, and the empowerment aspect of it was kind of undermined.
Yeah, totally. So do we need to have nursing homes be like co-op facilities where the workers actually own? I mean, that's thinking big, but the workers are in charge of the facility and they are part ownership. I mean,
well,
what a great concept. That would totally provide value-based care.
Well, we certainly see, on average, higher quality care in not-for-profits. Do you know of any organizations that are actually on a co-op model? I'm not aware of any.
So I was just there's a facility opening up here, or has recently opened up in Sacramento, California. I can send you I was quoted in the SACB article, and there was a group of nurses came together, and they are running this facility, and the nurses are all part owners of this facility. So
it's analogous to the physician-led ACOs, where better outcomes have been seen in the physician-owned organizations as opposed to the hospital organizations.
Yeah. So how can we empower direct care workers? How can we empower nurses? Even physicians, if they're want to be part of this. I see that as value-based care, and that's the only way if we want to infiltrate a value-based care model in long-term care, because otherwise, as you mentioned, it's just going to go at the top. The administration is going to be the one, or the owner of the organization is going to be the one who's going to determine where that money is funneled to.
So turning to HCBS, there's one challenge that I see in applying some of these concepts in the HCBS side. Both the upskilling and the value-based payment models really, I think, rely on the agency-based delivery of care. And I don't see how you can apply those in the consumer-directed model of care.
Yeah, I'm not as well versed in that financial model of home and community-based service, so I can't speak too much on that. But it does make sense what you're saying. Be more challenging, certainly, especially with agencies.
Yeah, well, with the agency, I mean, if the agency is getting incentive payments for improving quality or maintaining quality, then they can pass that savings on to the workers.
And do they?
The direct care workers in terms of wages. Well, this is all a hypothesis.
Yeah.
I think that's the thinking, the philosophy here. And likewise, the agency is a vector for the kind of training that is part of the upskilling philosophy, because you would have sort of the economies of scale to actually deliver some kind of training and hire, train, and recruit workers based on their accomplishment of the type of learning. But on the direct care, on the consumer-directed model, it's a individual consumer hiring and training and paying their own individual worker. So it's not clear who would be doing the upskilling there. And it's not clear who would be doing the value-based payment and who would be managing that and determining those outcomes in that type of setting.
Yeah, we did a really innovative project here I was part of with Joanne Spetz called Support at Home. It was a home care voucher program for people who were not Medicaid eligible in-home support services, but also they were like middle income San Franciscans. And as you know, San Francisco is the most expensive city in the United States.
So we're talking
to live
low six figures income.
Yes, exactly. And so they provide a home care voucher program where they can hire consumer-directed care. And as part of that program, there was training involved for the actual direct care workers, but that was part of funding that the city provided. And so there was an entity that was providing care to help upskill the worker. Some of them were family caregivers even. But you would have to have somebody that would be part of the training and the upskilling of the workforce, definitely.
Yeah, and I think that's the challenge, right? There has to be some kind of intermediary or organization. So without kind of reproducing the agency model, there needs to be some sort of network that's providing the training and some obligation to participate in the training that's available. So I think that's kind of the challenge, especially when we're talking about, hiring a family member, people who live in rural communities. They don't necessarily have the time or energy or resources to do the training. So I don't think we've solved all the problems.
Yeah, no, this is going to be a bit, especially now with, we are expected to add 1.3 million more jobs by 2028 to this workforce with home care jobs. So we have to do something about this. We're working on a study right now with the rural home care workforce with these workers, and it is really, really, really hard to get a direct care worker into the rural health sector. Just getting somebody out there. So that's an area that I see as a future need.
So that 1 million workers, and then Scales also cites about a churn of about 7 million workers. So it's not just 1 million new jobs, it's 8 million hires that have to take place.
Because of the turnover.
Yeah, because of the turnover, because some of those, assuming a lot of those people are leaving this profession and going into a different profession.
Yeah,
so,
we've seen that with the pandemic, actually. There were so many job losses in other sectors, such as like the restaurant industry, when restaurants were closed, that some workers were shifting over to jobs that were available, such as in home care and long-term care. And I think this is mentioned in the Scales article. That's a short-term solution.
Yes.
We need, and that's why you've mentioned the upskilling is like, how can we improve working conditions for this workforce in order to make it a place that they want to stay? And it's only upskilling is only one area of that. It's also work environment.
Right. So what do you think? Where do you think these workers are going to come from? What do you think are some of the solutions we have? These numbers are obviously built off of demographic trends in the aging population in terms of increased demand for long-term care and also the long-term trend towards home and community-based services. But where are these workers going to come from? Are we training them? Are they coming out of vocational schools? There are all these. There's all of this talk about making community college free for people. Yep. And that's where a lot of this training, where you can get some of the training to do this work comes from.
Yeah, you and I are on the same. So I was going to mention Jill Biden's proposal for, obviously she's very devoted to the community college community. So her college plan is certainly an area. Many of our LVN programs or LPN programs are in community colleges, or our associate degree RN programs are in community colleges. So and they're in the community. So that's a pipeline for this workforce. Yeah, so that's one area.
Clearly wages have to be part of that conversation. Do you think wages, I don't know offhand, do you think wages are higher in home care than in nursing facility care? Maybe they should be.
Yeah, we did a study with nurses looking at the NSSRN data from 2018 and found that it was slightly higher in home care than it was in long-term.
What about for aides? Personal care aides versus CNAs.
Yeah, that would be a good study to look at, to look across sectors with that level of worker. Certainly, wages is probably one of the biggest issues. Is low wages. I would say the fundamental issue, and I think that's why we have Congress people like Debbie Dingell and Bob Casey wanting to expand and mandate these Medicaid reimbursements for HCBS, so that if we can get greater reimbursement for Medicaid, then hopefully we can have higher wages for the workers.
So this brings us to immigration. I don't think Scales really got into immigration in a lot of depth, but what do you think is the prospect for immigration or work permits or new creative approaches to expanding the workforce? Bracketing the political challenges, what do you think of the sort of technical, practical, and quality implications? And then let's circle back to the political.
Sure. Yeah, well, certainly the long-term care workforce relies heavily currently on an immigrant workforce. And I'm curious to see, this was something I've wanted to study, in the past 4 years, was what has been the impact of our previous administration's immigration policies, and how did those policies impact our ability to hire within the long-term care workforce? So did it decrease our ability to hire workers into the workforce if we didn't have as much of an immigration stream coming into the United States? So that's something that might be an area of interest of research for somebody. The other area that I see, not only with the immigrant workforce, but also people of color are a large proportion of workers in the long-term care workforce.
Yes.
And so I think that those groups come together. There is some overlap certainly as well. And these two communities have especially been impacted by our pandemic. And so that's likely why we also had such, epidemics of cases in long-term care, because our workforce, immigrant workforce, people of color, primarily affected by the pandemic, they're working in long-term care.
So it's kind of a double hit, because on the one hand, we've had a political mood that has really de-emphasized immigration, has not wanted to see more immigration, has reduced the number of people immigrating. And at the same time, we had the pandemic, which reduced or essentially eliminated cross-border flows of people, or at least for a paid work in the cash economy, above the board work. So setting aside the pandemic, because we don't know when that's going to resolve, what kind of immigration policies might ameliorate some of the long-term care workforce challenges?
Yeah, so we have certainly worker permits programs. There's also been, if you look at the almost exploitation of nurses from the Philippines, those recruitment efforts that occurred in the 90s and still occur today, primarily focused on hospital nurses and less so on long-term care. So when I look for ideas around long-term care, I often see what my colleagues in the hospital are doing, and I've certainly done that in the past year. Like, what kind of supports are hospital administration? What kind of supports are they providing their staff during the pandemic? And so we're actually doing a study. As an aside, we're looking to see, hey, what kind of supports were long-term care staff getting during the pandemic? Were they getting their meals covered and parking covered and and all of this, like they were in the hazard pay? So that's also been brought up in the Scales article. So
are you seeing any of that? Yeah.
Very little in long-term care. Yeah.
The thing that I was thinking about at the height of the pandemic last summer was family housing for long-term care workers, as a way to say, hey, look, this isn't going to last forever, but it's going to last a long time. And the most important thing that we can do is to sequester the workforce. And it has to be a family-based policy, not an individual policy. And I have not heard of any localities really doing that.
Yeah. So if a family member of a long-term care worker was tested positive, was that worker able to go to a hotel for 10 days and, be quarantined from their family members so that they could still work at the facility? Or I know here in San Francisco with the nurses were able to just sign up and go and stay in hospitals whenever they wanted to. And so
But if that nurse is caring for an elderly parent, and the elderly parent is the one that has COVID, the nurse can't just go and stay in a hotel for 10 days.
Yeah. Good point.
Because they're also a primary caregiver. So they're and I think that's even more, impacted in the nursing home workforce.
Yes. So what kind of family leave or what kind of family leave options are available, for example, for workers or sick leave options even?
Well, I was kind of going in another direction, which is we can't afford to let people go offline. So we bring the whole family into an apartment setting and even do it prospectively and say, okay, none of you guys are sick, but we're gonna have to take you out of your community and give you the supports that you need for 2, 3, 6 months so that you can work, but then you're not circulating in the community and exposing yourself, or family members, the direct family members of the worker are exposing themselves to COVID in the community.
wonderful concept. I would love to know if any of that happened or is happening. Yeah. What stories are we seeing out there that facilities are supporting our staff? Because the stories that we're hearing is the mental health impacts, especially burnout, that this is having on our workforce.
Yeah. Yeah.
So I would love to see some positive stories of support.
Yeah. I don't know. I haven't seen them yet either. So Laura, what are you working on now?
Oh, too many things. I've mentioned a few of them already. As I said, a lot of the projects, we do these short turnaround projects with our workforce center. One of the studies that as I mentioned before, that we're working on is this rural home care workers. So trying to get out there and identify who this workforce is, who they're caring for, primarily older adults, people with disabilities, children. And so how do they gain access to the workforce? How do the clients gain access to a care provider? So we're doing some interviews around the country. We've even gone up to Alaska, which is a very rural area, to interview some workers up there. So that's been a great experience. Cotton farmers down in Arkansas. We've interviewed a few family members down there. So
very interesting.
So that's one study that I'm working on, and I think that the implications of that study will really come out with just like this HCBS Access Act that Debbie Dingle, as I keep mentioning, is going to be really important for policymakers to see the work that highlight the need for a stronger rural home care workforce. As I mentioned, the other study that I'm working on is, how has COVID impacted our most frontline long-term care workers? And we're calling this study In the Trenches. So who are those workers? Are the laundry workers, the kitchen staff, the CNAs, the activity assistants, and what kind of supports did they receive during the pandemic? Did they get hazard pay? If they got hazard pay, are they still receiving hazard pay or an increase in their wage? Or did they just get it for the first month? Their parking, their meals, do they get sick time so that they can go get their COVID shot? As you know, our immunization rates in the long-term care workforce are really low right now, and we need to do a better job of immunizing our long-term care workforce. And identifying ways that maybe that we can mandate it like the UK has. And so those are some of the things that we're working on right now with the current COVID situation. And as I mentioned, the most striking finding that is coming out of that study is the mental health impacts on this workforce. And so how can we, as a long-term care infrastructure, how can we provide better mental health care to our workforce? So I think that that's an area of further work.
Those are both very exciting, very important studies. I look forward to seeing the results.
Yeah, thanks.
Well, thank you very much, Laura. I really appreciate you taking the time to speak with me today about these important studies and workforce.
Oh, it's been a pleasure, Howard. Thank you for inviting me.
Thank you. Thanks for listening. To learn more about the Gerontologist and to read its latest articles, visit the website at www.geron.org. The Gerontological Society of America was founded in 1945 to promote the scientific study of aging, to encourage exchanges among researchers and practitioners from the various disciplines related to gerontology, and to foster the use of gerontological research in forming public policy.